Welcome back. Today we're going to talk about acute kidney injury, which unfortunately is an all too common problem on a general surgery service. Today what I would like to go over is how we classify these injuries, what the most common etiologies are, what is a reasonable way to work these patients up, and we'll talk about some prevention strategies. And lastly, we'll talk about renal replacement therapy for patients who are slow to recover renal function. The definition of acute kidney injury is an abrupt decline in the glomerular filtration rate. Practically speaking, this is going to manifest itself as a rise in creatinine, and usually, but not always, a decreasing urine output. There are several different staging systems in clinical use, and we'll quickly review several of the most common ones. The Rifle criteria is probably the most common classification system in use. Patients are stratified based on their creatinine level or their urine output, and they're put into one of 5 categories, depending on these numbers. And so there's 5 different categories, beginning with risk and progressing all the way down to end-stage renal disease. I would point out in particular the loss category down here. It drives home the point that patients who have not regained renal function after 4 weeks are unlikely to do so. So most of these patients will progress to end-stage disease requiring dialysis. The other common classification system is the acute kidney injury classification criteria. This is very similar to the Rifle criteria we just looked at. This system makes some minor tweaks to the creatinine and urine output thresholds for the various stages. This system also eliminates the loss and end-stage renal disease categories as well. Interestingly, the American College of Surgeons has several different definitions on what constitutes acute kidney injury. The Committee on Trauma defines AKI as a creatinine increase greater than or equal to 3.5 milligrams per deciliter. The National Surgical Quality Improvement Project, or NSQIP, defines the problem as a creatinine increase greater than 2 milligrams per deciliter over baseline. So now we've seen several different definitions of acute kidney injury, and which one's best or which one's most correct is simply not known. Now, if you're a doctor who daily takes care of patients in the ICU, you really don't need a classification system to take care of patients. You're going to be confronted with a patient who has a declining urine output and a rising creatinine, and you're going to have to make clinical decisions. And none of these staging systems offer you any advice on how to take care of the patient. So what is the point of these staging systems, or staging systems in general? And what they do is they allow you to look backwards. They allow you to review your results and see where there may be opportunities for improvement. So as a practical example, let's say you work in a burn unit, and you're interested to know what percentage of patients who present with a 30 to 50% body surface burn go on to develop acute kidney injury. That would seem like a pretty reasonable thing to want to know. But the first thing you're going to have to decide is, what is your definition of acute kidney injury? And sometimes the results you want to report will influence that decision. So if you choose the Committee on Trauma definition, that's a pretty stringent definition. And you're likely to find relatively few of your patients fulfill this criteria. However, it's also quite likely that a higher percentage of these patients would require dialysis, and they likely have a higher mortality rate. If you were to choose the lower number, the 2 milligram number, you're likely to find that you have more patients who develop acute kidney injury, but a relatively lower percentage of them are likely to require dialysis, and there may be an overall lower mortality rate when you use this less stringent definition. And so all this is a very long-winded way of saying that when you review the surgical literature, when you read a report from someone or some ICU talking about acute kidney injury or anything else that's classified, the first thing you need to know is what classification system are they using if there's multiple ones in common use, because that's very much going to influence the kind of results that they report. The pathophysiology of acute kidney injury is generally divided into 3 separate groups: prerenal, renal, and postrenal. The prerenal etiologies are all related to hypoperfusion. On our service, hypovolemia and hypotension would be the 2 most common reasons by far. Occasionally, we'll have a patient with a post-op MI who develops heart failure and has poor kidney perfusion on that basis. And perhaps even more rarely, we might see a mechanical problem with the renal artery, either an occlusion or a stenosis. The renal etiologies for acute kidney injury are related to toxins and drugs that directly damage the filtering apparatus. IV contrast is a particular problem on the vascular surgery service since they use it a lot for diagnosis and therapy. There are multiple drugs that are known to be damaging to the kidneys. Fortunately, some of these drugs are not used much anymore. Gentamicin, for instance, used to be heavily prescribed on the general surgery service, but it has largely been replaced by other non-toxic alternatives. Amphotericin B, once upon a time, was the only drug available to treat significant fungal infections, but now there are many better, less toxic alternatives. Tacrolimus and cyclosporin are heavily used on the transplant service, and they have a very high rate of acute kidney injury associated with them. We're starting to prescribe NSAIDs more and more for post-op pain control, and although we're generally aware of the effect of NSAIDs on the gastric mucosa and the increased ulcer rates, it's perhaps less obvious that NSAIDs are also damaging to the kidney, and patients who are taking a lot of NSAIDs for back pain or chronic pain also can develop kidney failure. We also see patients with pignate nephropathy. The most common situation would be rhabdomyolysis related to compartment syndrome. Hemoglobin lysis as a consequence of a transfusion reaction would be another instance of this. Postrenal etiologies are related either to mechanical or functional obstruction. During pelvic operations like low anterior resections or abdominal perineal resections, ureteral injury is a possible complication, either unilateral or bilateral. And in the post-op period, a patient who's had one of these procedures who's not making urine, once they've been adequately hydrated, they're going to need to be worked up by ultrasound for obstruction. These same operations also can result to injury to the pelvic parasympathetic nerves, resulting in bladder dysfunction. And so these patients will often require a Foley catheter for anywhere from several days to several weeks. Fortunately, most of these nerve injuries improve with time. Urethral obstruction is another possible problem. Most male patients over 60 have some degree of benign prostatic hypertrophy, and inability to void post-procedure is fairly common in this age group. On the trauma service, pelvic fractures can directly cause urethral transection, which would be another reason for obstruction. It's usually pretty evident when one of our patients is having postoperative acute renal failure. They'll be oliguric or sometimes anuric, and their labs will show a rising BUN and creatinine. And so our attention will have to be turned to the etiology of this problem. And the timing of when it develops is a useful clue for us. If the patient develops a kidney injury within the first 48 hours of their surgery, almost invariably the problem is going to be hypovolemia. If you're unfamiliar with the patient, you will need to go see them, and you'll need to review the operative notes, anesthesia records, and any nursing records that are available about inputs and outputs, and try to get your best assessment as to what their volume status is. Most patients within the first 24 to 48 hours will need more fluids. However, as time goes on and you get to day 4, 5, or 6 post-op, other causes start to become more important. Sepsis starts to rear its head, and drug injuries can start to manifest themselves during this time. And so your exam and your evaluation of the patient who's later in the post-op period would likely be more directed towards sepsis, potentially cardiac issues as well. In cases where the etiology of the acute kidney injury isn't clear, urine studies can often be helpful. You may see the presence of free hemoglobin or myoglobin. The presence of casts indicate tubular necrosis, which is usually the result of drug toxicity or IV contrast. Urine electrolytes and osmolality can also help sort out whether the patient has a prerenal or renal etiology in the unclear cases. If you're trying to sort out whether a patient is hypovolemic or not, then an elevated urine osmolality can provide additional evidence in that direction. However, this test is not very discriminating because many patients who have a direct renal injury will also have a very high urine osmolality. The classic test to help sort out whether a patient is prerenal or not is the fractional excretion of sodium, and you see the formula written down here. There's a couple of things to be aware of. A patient who has a FeNA less than 1 is very likely to be prerenal, and someone who has a FeNA greater than 3 is likely to have a renal or postrenal cause. However, this leaves a large gap, and many times you'll do this test and it'll come back with a value somewhere between 1 and 3, in which case you're no better off than you were before you did the test. The other issue is that the urine and blood need to be sent at the same time for electrolytes. A common scenario is the blood is drawn in the morning, and then somewhere later in the day, you get the idea, or your attending gets the idea that you want to get a FeNA, and so you order the urine to be sent. But there can be a many-hour gap between the blood and the urine studies, making this test less accurate under those circumstances as well. The patient who's anuric after a pelvic operation like a low anterior resection or abdominal perineal resection is a particular challenge. Initially, we'll assume hypovolemia and will resuscitate the patient with fluid and blood as necessary. However, if their urine output doesn't pick up, obstruction of both ureters is a likely complication. The test to rule this out is an ultrasound, and you'd be looking for hydronephrosis as evidence of obstruction. Doppler ultrasound is also useful for detecting renal blood flow. This is particularly valuable in post-op kidney transplants, especially if the kidney's not working when they come back from the operating room. The Doppler can assess whether your arterial or venous anastomoses are patent and functional. Since acute kidney injury increases post-operative mortality, preventing this problem is a worthy goal. The main strategy is volume expansion. So any patient who's due to get an IV contrast study should be volume repleted to the extent that they can tolerate. Some surgeons and some radiologists will often add N-acetylcysteine to the volume expansion regimen. This drug functions as a free radical scavenger, and many doctors like to use it, but as far as I can tell, it's of unproven benefit. Lastly, one should avoid using high osmolarity contrast agents, since these are associated with a higher degree of kidney injury. Besides fluid resuscitation, there are a few other preventative strategies that are useful in selected cases. Mannitol and Lasix are often used to promote a diuresis in kidney transplant patients and patients with rhabdomyolysis. However, any diuretic is contraindicated in a hypovolemic patient since they'll just worsen the underlying kidney injury. Phenaldipam is a drug that increases renal blood flow by stimulating the dopamine 1 receptor on the renal vasculature. This drug has found some use in high-risk patients, namely patients undergoing cardiac surgery or liver transplantation. But overall, this drug does not appear to reduce overall mortality or the ultimate need for dialysis. If a patient's kidney function falls below a certain threshold, then they will need to be put on dialysis. In many of our patients, this will be a short-term treatment, since a lot of people will ultimately regain meaningful function. However, a small percentage of our patients will ultimately be lifelong dialysis patients. Volume overload, along with life-threatening hyperkalemia and severe acidosis, are three of the most common indications for dialysis. Uremic encephalopathy is also a significant clinical problem, and we start to see this as the BUN gets greater than 80 or so. Hemodialysis is by far the most common renal replacement therapy chosen. It is extremely efficient at removing volume, manipulating electrolyte concentrations, and clearing toxins. However, the treatment itself is associated with many complications. First of all, a large central venous catheter needs to be placed, and so access complications can occur, as well as line sepsis type complications. During the treatment itself, hypotension can result from the large volume shifts, and sometimes this will require treatment with a pressor agent. Bleeding may result because the patients have to be heparinized to prevent clotting in the lines. Disequilibrium syndrome is a very distressing problem for patients and family members. In this syndrome, the patient may come back from a dialysis session with mental status changes like disorientation, confusion, or even obtundation. This results from osmolarity changes that ultimately can result in increased cell swelling in the brain. Lastly, arrhythmias are frequent as well due to the rapid changes in electrolyte concentrations. One of the main problems of hemodialysis is the hemodynamic instability that occurs in critically ill patients. And so continuous renal replacement therapy was developed to try to minimize the cardiovascular lability that happens during hemodialysis. Some of the potential advantages of this treatment include a slower but more consistent removal of sodium, water, and electrolytes. Basically, it's a smoother ride for the patient. Some have also proposed that there might be an enhanced clearance of inflammatory mediators, which might confer a benefit in the septic patient. However, in spite of these potential advantages, there has never been a documented survival advantage for continuous renal replacement therapy over hemodialysis. Continuous venovenous hemofiltration is the most common way that continuous renal replacement therapy is instituted. It does require a central venous catheter as well as a blood pump, and the process works by a mechanism called convection, which simply means that positive hydrostatic pressure is used to drive water and solutes across a filter membrane. So this approach allows for continuous fluid removal with minimal hypotension. However, it won't do anything to alter electrolyte concentrations. If it is important to fine-tune electrolyte concentrations, then you can add a dialysis membrane to the circuit. This then becomes known as continuous venovenous hemodiafiltration. Peritoneal dialysis is another approach to renal replacement therapy. This technique uses the peritoneal membrane as the dialysis membrane, which makes it much less efficient than hemodialysis. However, this inefficiency is what makes it so well tolerated hemodynamically. The way this technique works is that the patient does have to have a surgically implanted catheter with one end of it going into the peritoneal cavity. When the patient comes home in the evening, they connect the dialysis solution to the catheter and run it in. They then cap the catheter. When they wake up in the morning, they can drain the fluid out and go about their daily life. And so peritoneal dialysis allows patients to have a more normal schedule, and they can hold down a conventional 9-to-5 job. Patients who are undergoing hemodialysis find that their life revolves around their 3-day-a-week dialysis schedule. The next topic in this series will be acid-base disorders. For those of you who are interested, this website contains a written version of everything we talk about in these videos.